Lois face. Bunion deformities, there we go. The bunion, hallux abducto-valgus deformity. That affects 33% of the adults. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. Okay, so 3 or 4 of us in the room have a bunion. Oh, and everyone's flashing their bunions. Yeah. They're cute, yeah.
Oh, yeah.
In any sense, 33% of the adults. So don't feel like you're not in a lot of company. I mean, if you got one, so, 1 in 3 or so, no. The causation is really, a setup. And maybe you have encouraged it with your stiletto Kohan shoes, but maybe not. It could just be a setup. And the problem with bunions is that they dynamically worsen with time, whether you do everything or nothing, okay? We see pediatric bunions, and they didn't do anything wrong and the parents didn't do anything wrong. It's just that, there was a genetic factor. And they do worsen with time. We don't choose to correct them in a skeletally immature patient, usually. Now the growth plate on the first metatarsal is lower down, and sometimes we'll reposition the bone in this level here, but that's only if it's relatively mild. And believe it or not, a lot of times when we see pediatric patients with a bunion, they tend to be pretty good sized ones. So we'll usually wait them out until they're done growing and then correct them if they're symptomatic. So the clinical presentation is a deviation of the great toe, prominence here. And you can get pain underneath the lesser metatarsals, which you guys all know where those are now because of our anatomy discussion. And pain localized to the bump, if you will. So, some of these can get really bad. I mean, I wouldn't want this. This doesn't seem like it would be fun. But I don't have that, though. I have really good feet. Sorry. Clinical evaluation is basically, taking an X-ray and assessing the reducibility of the deformity and areas of pain, hypermobility, how mobile it is, and if there's any pain on range of motion, are all things that we use to decide. So we take an X-ray and we kind of come up with this angle interpretation and sesamoid position, which are these pea-like bones. I forgot to mention the sesamoids. You guys should have reminded me about that. But the sesamoids are 2 pea-like bones that sit underneath the metatarsal traditionally. Those are one of the 26 bones in the foot, 2 of the 26. So anyway, we interpret these angles, right? And the angle is what drives the location of the procedure. Okay? So a bunion is not just a bump. It is an angular deformity between the first and second metatarsal. The bigger the angle, the bigger the bunion. And in order to correct it, you would have to reduce this angle down to an acceptable level. The common acceptable number for this angle is 0, which would be parallelism between the first and second metatarsal, to 8 degrees. If you're beyond 8 degrees, you are in that category of a bunion. And it can worsen with time. So is all that clear? A bunion is just not a bump. All right? Now, people do bunion surgeries where they just remove the bump. And that's usually reserved for, maybe a very elderly patient that can't really recover from a surgery, maybe a patient with an ulcer or something unreasonable. But really, if someone comes to me and they're ambulatory active and they want a bunionectomy, that bone's got to be cut and repositioned and straightened. The first metatarsal must be cut and repositioned so it's parallel to the second metatarsal. And many things come into play, as I said, bone quality, other associated problems, medical history, so on and so forth. So, you guys are here, and we got some people from abroad, even though we can't see your feet. We feel a bunion out there. I don't know who you are, but you got one. So do you need surgery? Well, conservative treatment's really limited. It's basically like, great, I got a bunion, I'm going to live with the thing. You know, interesting enough, a non-surgical journal, JAMA, Journal of American Medical Association, in May 2001, looked at bunions, and you guys can't, I don't think you're going to be able to, can you guys read this on the bottom? Yeah. No. No. Let me read it to you, because you can hear me, right? Yes. JAMA concluded that for moderate to severe hallux abductovalgus deformities, surgical correction is the most appropriate, effective method of treatment. Now that's interesting because that's a non-surgical, non-biased journal. So, you know, if it was an orthopedic or podiatry journal, we'd say, well, of course, but this is JAMA, you know, and it's interesting. So, nuts and bolts, I think if the thing is bothering you and hurting you, my story is that it usually will not get better with time, and therefore, as I've seen in the time I have lived so far, things don't usually stay the same. So if it's not going to get better, like that bottle of red wine I have in my basement, and it's not going to stay the same, the only alternative is that it's going to worsen with time. And that's what happens with bunions. They will worsen with time. Relatively simple bunion. Relatively simple correction. The bone is repositioned and held with 2 screws, and the toe is rectus and happy, and everything looks good. Actually, it might be my neighbor. The next one slide is surgical procedures, and again, one locale is up by the head or the great toe. That's a repositional osteotomy over there. Common terms, Austin bunionectomy. Sometimes it's further back, like in this right-sided picture on the bottom. And these go to the base. And some of them you have to stay off of. When you start going back down here to the base of the metatarsal, you can be sure that you're not going to be able to weight bear on your foot. And then sometimes it goes even further back into this area. Like, look at this thing. Who would want that foot? These are bunion extraordinaires, right? I know who wants it. Me. Because I love correcting that type of foot. That's right up my alley. All right, so this is a complex deformity. You guys can't really see. This is a pre-op deformity, and it's more complex because you would say, well, they don't really have a bunion because they're parallel here. But this person has an angle all the metatarsals over. So what had to be done on that foot is we had to cut and reposition 2 of the bones. And unfortunately, it gets kind of washed out here. There's screws and a staple in here, but you have to take my word for it. It's perfect. It's actually a nurse that works among us who we can't tell, but it came out really good. And she's a good friend of mine. She likes me, and I like her, because I like AORN. This is great. Anyway, more complex surgery. Now this patient was in Central Maine orthopedics. This is you know, the complexity that they get. You know, these are complex deformities, and the patient came in and he had a non-healing second metatarsal fracture. Do you see the second metatarsal fracture? Oh, yeah. Can you see it? I should have made those arrows big. I didn't know you guys were going to not have some great... Yeah, they can see it. So, you know, people are treating this guy for months with, you know, for a second met fracture, and they're not realizing that really the true causation is this guy's extreme angle. So, you know, we fix him. There it is, a lot of metal. But you could see that parallelism is now achieved between the first and second metatarsal. This is, again, another patient we had over at Central Maine Orthopedics. This is with a twist. This is a rheumatoid patient. Rheumatoid arthritis can create severe deformity. This side is corrected and was worse than the other side.